Hello, and welcome to this week's episode of Ladies, Let's Talk About It. I'm your host, Dr. Denise Jagru. I'm a board-certified clinical specialist in women's health physical therapy. Today, we're going to be talking about a little bit heavy topic. So we're going to be talking about trauma, sexual trauma, pelvic trauma. But to help me discuss this today is my very good friend, Amy Hill-Fife. She's also a pelvic floor physical therapist, and she flew in all the way from Colorado to be with me and discuss this very important topic. So I'm going to let her introduce herself because I just want to, do it justice.
Oh my gosh. Thank you so much for having me, Denise. This is amazing. You are amazing. Oh, I love it. So thank you. Okay, so my name is Amy Hill-Fife. I am a pelvic physical therapist. I'm board certified pelvic and women's clinical specialist, just like Denise. I have been a pelvic PT and orthopedic PT for 26 years. I'm starting to show my age. I am also a certified sex counselor and currently have an application in for a high-level certification in that area. Looking forward to it. And in the hospital system that I work in, I have co-created a program with a social worker, and we talk a lot about pelvic health issues, mental health issues due to sexual trauma. So Denise has graciously invited me to talk about this important issue. So thank you. Very important.
Thank you for being here. So with trauma, it can feel heavy. We're going to try to make it digestible.
Mm-hmm.
And for us, this is something we deal with every day. So we're very comfortable talking about it because the large percentage of our patient population has a history of trauma. And this is not something that maybe is evident as like someone, we're physical therapists. So we also treat people who have like knee pain and like back pain and injuries from physical trauma. This can be a very like hidden, invisible kind of trauma, and it doesn't always get addressed. And I think like, one aspect of this I feel is like, we put a lot of blame on the patient for not reporting it.
Mm-hmm.
And I think a lot of the blame should be on the providers for not screening for it, and they don't know how a lot of the times, and they don't feel comfortable with it. So one thing I'll say is like, I work in this hospital and I did this whole project on like screening for trauma. And, I talked to the patients and the patients said like, they didn't feel comfortable reporting it because the doctors don't face them, and they're asking them questions. They have their back to them and they're on their computer. And maybe they're female patients and they didn't feel comfortable reporting it to a male physician.
Right.
They didn't feel anybody cared. They didn't feel like anything was going to be done about it. They thought they would be punished for it. There'd be some kind of like repercussion. And it was so sad to hear this. And I did this whole presentation and I studied the training that the providers got for it. And they were basically the residents of the hospital, and they had like a 5-minute training.
Right.
Like they did not understand trauma as an experience as opposed to diagnosis.
Mm-hmm.
So like I did this whole presentation. I went over everything for like at least an hour. And then I like put it out to them again. Like, do you feel more comfortable now? And they were like, no. They still didn't really like understand it. And like, someone who's getting a 5-minute training or a little talk about it is not really going to understand like, the experience of trauma and all the ways that it can manifest in someone, because your body is another way to, like, it's another voice, right? Like if you're not speaking, your body's going to speak for you.
Right.
And you're going to have trauma expressed somehow, like it's going to come out somehow. So there's so many different ways that people can express trauma.
Mm-hmm.
So do you want to talk about any of the ways that people may, feel like they end up expressing trauma?
Yes, about the survivors and thrivers who've had sexual trauma. Yes. So I think it's overlooked because a lot of us didn't have the training. A lot of medical professionals don't have the training. And then when we have, if we're going to speak mainly about women today with sexual trauma, although men can also have sexual trauma.
And that gets ignored completely, I think.
Yes. So different populations have different numbers of trauma. So in the general population, the number is basically 1 in 4 females have had some type of sexual trauma. In the hospital system we work in, it's 1 in 3 individuals, females who've had trauma. And then men, it's 1 in 50 men report. So we know the number is higher, but that is what gets reported. And in the general population, I think it's 1 in 8. I could be wrong on that number. So someone will have to look that up. Men or males in the general population. So it's very high. And the issue is that, first of all, the person that's experienced trauma doesn't have a way, there's no treatment. A lot of times they don't tell anybody because it's shameful. Maybe they've been threatened. They don't know who to go to. Maybe they've even gone to a hospital system or an emergency room and they haven't gotten the help they wanted. So they just sort of push it down. And then, like you said, it's invisible because maybe it's pushed way back in the back of their mind, or they just haven't dealt with it. So possibly when we see them or when a physician sees them, they may be angry. They may be upset that their appointment got canceled, and they may be coming across very aggressive. They may decide that they're just not going to show up anymore for appointments, or maybe they come 30 minutes late, or they just disappear on you. Maybe during the appointment, it's almost like they just sort of glaze over and freeze or disassociate. We can have that, or they can be very people-pleasing. So maybe they don't really want to have an exam, but because the medical professional is saying, oh, yes, we need to do this exam, they're like, okay. And then during the exam, they actually disassociate and disappear. So there are a lot of different ways that the survivors can present, and they don't know what's happening. And if we don't know as a medical professionals what's going on either, we won't recognize what is happening. And so those are a few things of the presentation. I'll talk more and I can tell a story. Do you want me to tell a story about my first day at my new facility? I had a patient in, and she was crying and sobbing and screaming very loudly. And she was saying, now she had sexual trauma. So she was already triggered. She was nervous. She was afraid to be in a closed room. Even it was female, and I was her female clinician, and she was still afraid. No one's listening to me. I don't want to be here, et cetera. And so, and she had been deemed as a difficult patient. Now, remember, this was my very first day of work here, so I didn't know her. And I just felt like something is very off. Something's going on beyond what she is expressing. And so it ended up, she had come with someone who was in a wheelchair. And so I called my boss, and my boss, we got a wheelchair for my patient. I pushed my patient. He pushed her companion in the wheelchair. We're going over, to get to the emergency room, and she's screaming the entire time. There's people all around us. It was so, it was so nerve-wracking for me, and I felt like I didn't know what was happening. And so, anyhow, we did get her to the emergency room, and she was saying she had an issue. So this is also very interesting because it compounded, because she's like, something's wrong. I have something going on with my lungs, or I can't breathe, or I have pain in my heart. Well, she ended up having a pulmonary embolism, which is a blood clot in her lung. So she was also having some medical gaslighting, I would say. And so that was discovered. And then on top of that, she was very triggered because of her history of trauma and not wanting people to touch her very much and be close to her. And when you're in an emergency room or you're in a PT office, people are touching, they're doing things to you, and you don't have control. And so it was very interesting after we figured out, the emergency room, the physicians figured out that she did have a pulmonary embolism. She came back to see me, thanked me for listening to her. And then we also started discussing and talking about what was going on with the sexual trauma and how that was affecting her as well. So that was my first day. And I realized, wow, I need a little bit more education and learning.
Yeah. Yeah, it can be very complicated. It can be very layered. Like trauma just in general, but people there's this trauma center somewhere in California, and they have this really great infographic about like how many women, can experience trauma, have a history of trauma, but also that like the way people express it, like maybe they're promiscuous, and it's also like this kind of like control, like, they can be with as many people as they want, or maybe they have trouble holding down a job or like maintaining an apartment because they just like they dissociate and they like lose focus and they disconnect with like responsibilities and stuff.
Right.
And or like physically, you can have like vertigo, or you can overexercise, or you can like have issues like with your stomach, just different ways like your body will speak for you. I always say, like, if you're not speaking your trauma, like your body will speak for you and express it. So a lot of times it's just, trauma speaking.
Right.
Really, and they're not processing it. So as much as like we might be seeing them for something physical, there's something really like layered mental going on.
Right. Right. And so when you talked about physicians not having the training, a lot of pelvic PTs haven't had training, nurses haven't had training. And so that's my passion of how do I get more people understanding what's happening with our patients. So when we're talking about that, your body speaks for you. There's a theory, polyvagal theory, that we'll talk about in a minute, but it's also what is happening with our nervous system. So when we have trauma of any form, our brain is affected. And so there's a lot of neuroscience that can go into this too, about what's happening in our brain and different areas in our brain and how the memory and the trauma is stored. So that's one thing. And then we have a system that the sympathetic nervous system and the parasympathetic nervous system, right, Denise? And so I always view it as a teeter-totter, and it's always wanting to be balanced out, right? Our body wants to sort of stay in this balanced state. And most of us know sympathetic nervous system as the fight or flight system. And that is fight, flight, freeze. Fawn is people pleasing. And you can have fail to think because part of your brain sort of shuts down. And then the prefrontal cortex, where we have our problem solving, that shuts down and our amygdala takes over. And so there are certain ways that we can work on that. And let's remember that all of these things we're talking about, these survival skills, helped to keep people alive.
Right.
So the fight part is some people will fight back or try to move towards a solution. The flight is fleeing, trying to run away. Fawning is the people pleasing. Freezing is where, some people faint, some people play possum. And all of these things are ways for us to have survived what we went through. And so that's one thing. I don't want to have people be shameful of these because they're amazing. And by the way, if we're driving here, like we talked about driving in Brooklyn, and a car comes over, we go into a sympathetic state and we might, have to quickly jerk the wheel, and we get flooded with all these chemicals in our body, and great, then we avoided an accident. So we want to have all of these systems working and sort of going up and down. The issue with trauma is we tend to get sort of stuck in that fight or flight. And if we're there too long, then we go into more of, they call it the freeze state, but more of where we are trying to conserve energy. Depression, hopelessness can be there. And so we're paying attention to all of those things. Then on the parasympathetic side, we talk about in our world, you've heard this, is the rest, digest, have sex system. And I changed it as a pelvic PT to the pee, poop, procreate, even if you're not trying to have a baby, peace, partnership, and play system. And so it's a different level of chemicals, or different chemicals going through our systems that affect our body. And that's sort of where the polyvagal word or theory comes in. But different chemicals affect things like our heart rate. Our heart rate might jump up, our blood pressure goes up. When we're in sympathetic state, we are going to release more glucose into the bloodstream. Our GI system shuts down because it's not the time to process our food. It's not the time to have a bowel movement. Your bladder will actually hold more urine because it's not the time to go to the bathroom, to go pee. Sex-wise, desire goes down because it's not the time to really be trying to have sex or procreate or do any of those things when we are more in a survival state. And again, we want those survival states for certain things. We just don't want to be in them for 10, 20 years. And that's where the issue can come about. And then that's where, the other thing about a sympathetic state is it creates an overall muscle tension. So migraines, tension headaches, holding our shoulders tight, TMJ, stomach issues, pelvic floor muscles, like the pelvic floor has around 26 muscles, depending on who's the anatomist. And those can go on lockdown and sort of go into a tense state. And we don't even know we're doing it, right? So, okay, I sort of went off on a tangent there.
That's all valuable information. But it's true, this all started from survival. This is all evolutionarily speaking, like from a primitive, like innate sense. Like if you are in danger, you do one of those 5 things. And you're right that it was always just, fight or flight, and like really learning the other things. And I've learned these other things over time, because like when you're trapped in a situation, if you're, you think you're going to be assaulted, but like fawning, and like doing whatever the other person wants so they won't kill you, they won't hurt you, so you can escape. Like that is another strategy.
Yes.
And that is just, that's something that like, people feel shameful about, that like, oh, I gave in so they would, but really it's to let you live, and to let you escape.
Right.
And like, these are all very natural kind of tendencies that people have, like innate things to escape.
Right.
Survive.
And so I think when we can help survivors understand that, hey, this was a great thing for my body to do for me. And maybe now that I've been living this way for 10, 12, 15 years, that I want to learn some other skills and some other techniques on how to bring that part of my teeter-totter down and bring my other the parasympathetic side up, which we know that there are researched treatments that do help. So when we go back to the pelvic health world or the physician world, right, where patients aren't even screened for sexual trauma, it is true, because the patient may not, they may be presenting, or the survivors presenting crying, and the physician's like, I have 7 minutes with this person, I don't know what to do for them. And so just becoming aware of what we're looking at, and from both the survivor viewpoint, like, oh my gosh, this may be what's going on with me. Like you said, one thing can be that people become more promiscuous. And so then it looks like they've got a lot of partners, and maybe that is not healthy for them. And they're going to the doctor because they're getting recurrent infections, and the doctor's thinking, oh my gosh, they're just promiscuous. They have too many partners, when in reality, there's something else going on. And so both people in that situation aren't quite sure what's happening. And then even if we do ask survivors, have you had any sexual assault? That's something that you and I probably ask. I ask every single patient. This is something I ask everyone. Have you had any type of sexual trauma that you would like me to know about? And sometimes some people can't remember too. Let's also address that. And that's okay. But like you said, the body is telling us something different.
The body remembers, right? And the body will express it. And also, I think people don't, especially in our hospital system, they don't realize what is considered assault or trauma, because to them they think being attacked, being raped. But there's so much more in that category,
right,
that can, like, something that you experience that affects how you function now. Like, I've had patients who, like, someone made comments, about their body. They felt really uncomfortable. And every time she was with this person, which was in a work environment, she had like just anxiety from it. So now when she's like in that setting, she just always has like this, heightened sense of like awareness, and like she's upset. She doesn't like to be given tasks with this person. And I'm like, well, this affected you. And so like comments, ogling or whatever, like looking, touching, like unwanted anything, like all of that can be traumatic. And it doesn't have to be that like someone, attacked you physically, whatever. There's so many different things that can qualify as trauma.
Right. And that's such a good point. So harassment, et cetera. So when we run the group that we run, that's one thing. We don't compare traumas. We don't talk about the specific traumas.
Right.
That's not brought up, because we don't want someone to think, oh, well, I didn't have as bad of a trauma as someone else, because it depends on the person and what they're going through. And then how are we responding to that? What is our body doing? Do we go right into a clenched jaw and then we crack a tooth? But we didn't realize that why we were doing that. But we went to work, and this person was here making a comment that makes us very, very nervous and makes our system on overload. So It's a very sensitive topic. It's challenging for everybody involved, I think, for professionals as well as a survivor. So again, your podcast, this is amazing because we're bringing awareness to what's going on, and people might start recognizing like, oh my gosh, my hands do get sweaty when I'm in this situation, or I sort of feel like my brain shuts down and I can't really think as clearly as I'd like to. And then they can realize, oh, okay, this is because of my specific situation now, or is it coming from something that happened to me 10 years ago, 15 years ago, 20 years ago?
Yeah.
So
when we talk about trauma-informed care, so from the point of view of the providers and being sensitive, to the patients in these situations, like I said, I asked the providers too, like, why don't you ask about trauma? Like, why don't you explore this more? And they're just like, I don't have time. I don't have time. And I said to patients as part of my project, I was like, if you had one thing to say to these providers who have like 5 minutes with you because they have busy clinics, whatever, like, what would you say? And they all said the same thing, like, make me think you care. Like, even if you don't care, like, make me think you care. Like, give me a questionnaire where you're asking about, like, even just saying, how are you, or whatever, like, just something make me think that, like, you care about my answers, to have their back to you, because they're, you're not going to be comfortable disclosing anything if someone has their back to you.
Right.
And they're like, typing. And then, or if someone just is typing and their back is to you, and they say like, oh, do you have trauma? Here's your trauma. And they're like, when I ask that question, I put down any paper, I put down pen, I look right at them, right? Because even if someone is saying no, if they're clenching their fists, if they are shifty in their movements, if they lose eye contact with me, that's a yes, And so I'm looking at body language, I'm in tune with the patient. And I feel like too often, like the provider is not like paying attention and not like picking up on these cues, and also kind of like dismissing it, like, oh, trauma, or your trauma wasn't that bad. I've had patients have practitioners tell them like, oh, you don't look like you're in pain, or like, just relax, like just whatever, like, just get over it, kind of thing, you know, because like, it wasn't that bad, or it wasn't as bad as this one, or like, you're making it to be more. It is always, like, whatever someone is feeling, that is valid, and we can't dismiss, what they're feeling. So in terms of trauma-informed care, like for us, like, it's really important for me to ask a patient's consent for everything. And when I'm teaching, I tell students, like, you have no right to anyone's body.
Right.
Like, if I put my hands anywhere on them, is it okay if I put my hands here? Is it okay if I stand here? Is it okay if they're sitting on a treatment table and I'm standing? I'm aware of that, because that can be triggering, that can be intimidating, right? So like, I always try to come down to their level, so then I'm eye level and they don't feel like intimidated by me towering over them. If I'm behind them, if they're in sideline and that's a very vulnerable position, right? So like, I want to be, I'm looking at their body language the whole time. Like, if they could say like, oh, I'm fine. But if they're like, they're not fine, right? So,
exactly.
So what are some things you take into consideration for?
I think it starts at the very beginning on how your front desk staff, or how the medical staff, front desk staff, then medical staff, addresses people, and really that warmness. And sometimes people need the same sex person. So if it's female, they would like a female checking them in, or calling them on the phone and discussing medical things, and just having that warmth. And it depends on the setting that you're in. You can't always like dimming the lights, having a room that is a little bit warmer, not too hot, not too cold, but something that's comfortable. And then like what you said is I will have people sit down and I'm sitting eye level, and I make the door available to them. So if they need to feel like they need to flee, the door is there. I am not blocking it. There's nothing blocking it. I also have a table in between us. So there's that little bit of a buffer, and they feel a little bit safer. And then same with me. I don't always get my notes done, because I turn and look at the patient I'm talking with, and I don't do anything with my notes. It does put me behind. And I do want to recognize, with physicians and the whole healthcare system the way it is now, they just don't have a lot of time. And they also, I feel with the medical providers, they don't know what to do if something were to go a little bit sideways on them. So that's something I think we can talk about and do a couple little tips. So oftentimes I'll dim the lights. I always ask, hey, because some people are not comfortable with the lights off. I have a window. Some people don't, but you can either dim the lights or ask if you can dim the lights. A lot of people are more comfortable with that. Sometimes I'll ask people if they want water, just sort of developing that rapport and that I am just being aware of what's going on. Same thing of describing what the appointment is going to be about today, sort of what we're going to do, describing anything that we're going to do. I do a lot of education and like, this is what this part of your body, your pelvic area looks like. If we're talking about, maybe they have a bladder or a bowel issue, because we deal a lot with bladder, bowel, sexual health issues, right? Maybe they have IBS. Maybe they have something like that. So really doing a lot of education and trying to normalize their body parts, because those body parts are also shameful, right? Everyone shames the pelvic area. We just don't talk about it. And so that's already a shameful area. And so I really try and normalize using the correct terminology and getting it to be more comfortable. Like, we can use the word vulvovaginal the same as we use the word elbow. We don't typically have as much emotion tied to the elbow as we do saying, okay, we were going to do a pelvic floor exam, or having, for women getting a yearly pap smear. That's very traumatic for people. So lighting, the warmth of the room, really trying to develop that rapport, which you can do in a minute or so, 2 minutes if you don't have a lot of time, and then describing everything we're going to do. Like you said, if you're behind them, I try not to be behind people, or if I do need to go behind someone, I tell them what I'm doing, asking, may I put my hand on your hip, etc. Now, I've had patients also tell me, though, they don't want to be asked every single time. So if I have my hand here or I'm doing an exam, they don't want to be asked, can I move my finger here? Can I move my hand here? Can I move my hand here? Can I move my hand here? They say that's too much. And that makes them feel like they are actually a victim. They're being treated as a victim. So that continuous consent, though, of saying, hey, this is the plan of what this exam looks like. How do you feel about that? Are you okay with that? And then we do go through the whole consent process, verbal as well as signing paperwork. And then during an exam of any sort, always making sure that the patient knows that we can stop at any time. And that's the continuous consent that we talk about. Now, what's interesting for us medical professionals is sometimes we may not recognize that our patient has disassociated. And so we could do a full pelvic exam, pelvic floor muscle exam, and it seems like everything's perfectly fine. And I have actually had this happen. This happened to me probably about 15 years ago. The patient came back the next time and she did not remember that she had actually come in for her first appointment.
Wow.
And I went, okay. This is when I was like, we are not getting the education that we need to help our survivors.
So in terms of educating providers, you are starting a program, certification program. Would you like to share a little bit about that?
Yes. So my goal, because of my unique, and same with you, we both have the same education, but the Pelvic and Sexual Health Trauma Competent Certification Program, which will be a 12-week program for healthcare professionals, medical physicians, nurses, nurse practitioners. I may open it to midwives, because also that's a very sensitive time when we're having babies, right, for trauma to come out. Physical therapists, pelvic physical therapists, occupational physical therapists. And the whole goal is to provide training, awareness on what is happening, being able to recognize what is going on in our patients, and then having the tools and the skills to feel confident that we can help someone, whether we have 2 minutes or we have an hour with them.
And so you said it's 12 weeks.
12 weeks online. It'll be a virtual program. So they'll be talking to professionals who are very, very busy with their work schedules, as well as families, et cetera. It's going to be asynchronous so people can watch the videos. And then they will be meeting in group settings with me for supervision and having questions answered, bringing up case studies, and making sure that they have the mentorship and the support that they feel that they need. So that will be several times a month and more if needed.
So there's in-person portions of it as well.
Yes.
So they have to fly out to Colorado?
No. Sorry. No, it'll be Zoom sessions. There'll be online sessions because again, everyone's so busy. We don't always have time for that. So I've been speaking to a lot of professionals and I said, what would work the best for you? And they said, I just need to be able to have the time to do this on my own, but I want the support so I know that I'm doing it correctly and I'm not re-traumatizing my patients. That's the other thing that happens often. So being able to provide that group setting supervision, but it will be all online. So they don't have to go anywhere and it won't be as expensive for them.
That's fantastic.
Yes.
So great. When do you think someone should see a pelvic PT if they're experiencing, if they have a history of trauma? And I don't think people think, right away to see. I mean, we always have to do a lot of advocating for our profession to get, referrals, let people know how many things we treat and what we specialize in.
Right.
But I feel like, people think the mental health aspect of it, but, we're treating the physical aspect of it as well. When do you think that someone should, come see us?
Well, in my perfect world, if someone has a sexual trauma, let's say a sexual trauma that is actually a physically damaging, so that would be more like someone who's assaulted, rape, etc. My perfect world would be that they would get to an emergency room, they would be treated by a physician and possibly a sane nurse who does a sexual assault nurse who does an exam and is treated right on the spot. Sometimes there's physical damage. People need stitches. People have things going on that are, that need to be medically fixed. And so I'd like that. And then I would say that the referral would be pretty immediate, right? Within 4 to 6 weeks afterwards. Now, we'd also want to see a multidisciplinary approach where they would also have mental health counseling as well, because that's going to be very, very important for their recovery. So that's how I'd like to see it. Now, if it has been years and years and years ago, then it is as soon as possible, really. As soon as you feel, people probably won't feel comfortable coming to an appointment. So it's getting the referral and coming to an appointment, even if they don't feel comfortable, right? And so then once they get in for pelvic physical therapy, then we sit down, start developing that rapport with them and slowly teach them what's going on in their body, why they may be having pain, why they may be having IBS, why they have bladder urgency, pain with sex, possibly why they're having so many partners, what is happening with that anxiety, and that chemical release, why they might be having migraines. And so we can help with all of those things, really, when we're looking at the whole person. And then the goal for the medical professional, pelvic physical therapist, nurse, et cetera, is that they have the skills to teach mindfulness, grounding, breathing techniques, all the techniques that can help bring that fight or flight, fawn, fail to think state down and bring the parasympathetic nervous system up. There are also skills. It's a DBT skill, dialectical behavioral therapy skills, called TIP skills that really work quickly. And, we can do this for kids that are going into sports that are really nervous. But if survivors find themselves in a space where they're really having a lot of anxiety, maybe it's a woman that it's time for her yearly pap smear, TIP skills. We can use temperature, so that can be like ice in the hands, a cold pack on the forehead, cold pack on the back of the neck. We can use the dive reflex. Intense exercise is the I. The P is paced breathing, progressive muscle relaxation, and those are skills that affect the system very, very quickly. And so if we or our patient is really starting to get upregulated, and we can tell they're uncomfortable, they're shifting, they're really nervous, we can use those TIP skills very quickly. A physician can use these TIP skills very quickly in the office to teach. So,
and even grounding, where they focus on something red or something that they see, something that they hear, just to get back to their senses and not spiral out.
Right. So having professionals know those trauma informed, but also those are what I consider, what I'm calling the trauma competent skills, that I, as a medical professional, feel competent that if I have a patient and I ask the question, do you have a history of sexual assault? and they start crying or getting really upset, that I have something in my back pocket that I can teach them immediately. I have a handout. I teach them how to use it. I can explain what's going on in their body system, and I can send them home with the handout and say, you can use this anytime you feel this way.
Mm-hmm.
And that it's a practice too, because we're trying to change some things that have been going on, 10, 20, 25 years or longer. So hopefully that makes sense.
Mm-hmm, mm-hmm.
Yeah.
And it's important to remember, like, there's no deadline, right? Like, people can be harboring, and manifesting effects from that trauma from, like, decades ago. So
Mhm.
like, if we get them soon after the trauma, that's great. But if it's years later, like, there's no deadline where, like, we can't work on this anymore. There's always room, space,
Yes.
time to heal,
Yep.
and to see a pelvic floor physical therapist and all the other resources to help and release this trauma. Like, be aware of it, connect with it, like, forgive yourself for it, and then, release it.
Right.
Because there's always going to be a part that may be holding on, and you have to, be ready to release that. So
Mhm. I know. I was just reading an article. That's so great that you brought that up. I was writing a blog post, and it was talking about that with traumatic brain injuries, there was like this 24-month rule that after that, nobody gets any better. And we know now from neuroplasticity with what's going on in the brain that is not necessarily true anymore. And so, yeah, exactly to your point, that it can be years after the actual incident. And there is always room for improvement and lots of skills that we can use to work not only on what's happening in the brain and the neural pathways, but bringing that into the body, bringing that into the pelvic floor, understanding what's going on, and then we can progress depending on the education of the medical professional, or if there's a medical or mental health professional, a sex therapist, sex counselor. I know you're going to have pharmacists on your podcast, so we also can get into medications that can help, right, with mental health issues, which can be fantastic. So now you've got your medical professional, your physician, as well as the pharmacist. But there are so many things that we can work on and really get people back into their bodies and connected with their bodies and understand what's going on and really heal from a whole person perspective, though. It is not just one piece or another. It's really everything together.
Mm-hmm.
So,
and is there anything else you'd like to add for today?
No, I just want to thank you for bringing this to people's attention and doing such a great job of educating everyone. And the one thing I will look at our audience and say, you are not alone. There's so many people, women and men, but women who have really gone through sexual assault, sexual harassment, and it can be very devastating. And now that we're talking about these issues more, you're not alone. And there are a lot of things, a lot of treatments, a lot of skills. There's yoga, there's mindfulness, there's working on so many things that we can do that you can get help. So do a little bit of research in your area, reach out to people that you know, look for pelvic PTs, pelvic physical therapists, physicians that are trauma-informed, trauma-competent, and go ahead and ask for help.
And how can people find information about your practice and your program? How can they find you?
Yes. So my main website is pelvichealthpt.com. And then for the program, for the professional training, the pelvic and sexual health trauma competent certification, that is going to be at apply.pelvichealthpt.com. And people can look through that website, and then they can click on a button and there's an application form for them to fill out.
Okay. I'm going to add all that in the caption so you have that information. Thank you so much, Amy.
Thank
for
you,
coming
Denise.
here, flying all the way out from Colorado to Manhattan, and being with me to discuss all this. It can be very heavy, but I feel like you really made it understandable and just digestible for everybody. And it's really complicated and layered, but trauma. If you're suffering, follow all the suggestions and recommendations from Amy. Seek help. You're not alone. Pelvic PTs can help you. And thank you for joining us today for this discussion. And tune in next week for another episode of Ladies, Let's Talk About It.